Uh, Very good morning to everyone. First of all, I would like to thank the organizer, specifically Iman, for bringing me here. Thank you for this kind invitation for this beautiful city of Cairo. And it's lovely to see a group of professionals uh, who are very keen in more of clinical and the research work coming together to share their knowledge and expertise. I was just sitting and watching the way the session is going on for the last 30-40 minutes. It was fantastic, and the way you conducted the consensus meeting was really impressive. I think this is something which I want to take back to the Indian societies as well. Thank you very much. So with that, I would like to start my presentation, which is on decision making. We as a clinician, we are sitting in one of the most important positions where we are often face situations where we find it very difficult to pull the shots, especially coming from a country like India, where most of the cochlear implants and the brainstem implant are private funded. It's very important that patient look up to you to make decision on certain scenarios, which becomes little tough for us. One of the common situations that we face is making decision between a cochlear implant and a brainstem implant in a patient with anomalous, cochlear anomalous nerve. So where do I come from? I come from India, and I come from a city called Chennai. Chennai is the southeast coast of India, which has got a beautiful beach. And Chennai is also the education and the health capital of India as well, with the highest literacy rate in the whole of country. And we have an institution called the MIRF Institute of Speech and Hearing, which was established in 1996. And we have undergrad, postgrad, doctoral program in audiology and speech language pathology. Now, coming back to the most important part, we all know hearing is one of the most sophisticated sense, yet the only sense that can be restored, even lost completely. See, no other sense can be restored if it is lost completely except for hearing. See, we are so fortunate in working in a profession where the lost sense can be restored. We have multiple solutions. In the last session, people are talking about solutions for conductive pathology, middle-ear devices. Now, looking at the focus here on the cochlear implant and auditory brainstem implant. Now, what is a cochlear implant? The cochlear implant is a bioelectronic device that converts the acoustic information to electrical signals and deliver the signals in the cochlea, in the spiral ganglion cells. What is a brainstem implant? Brainstem implant is exactly the same as cochlear implant. The only difference is it delivers the signal in the cochlear nucleus instead of cochlea, spiral ganglion cells. So, if you may see here, I don't know if you can see you can't see there, okay. If you may see here, this is the cochlear implant stimulation site, and this is the brainstem implant stimulation site, right? But I want you to understand, despite the cochlear implant and brainstem implant differ in terms of the stimulation site, the coding strategy is absolutely the same, like whether you for a brainstem implant or for a cochlear implant. So which simply says that we have not customized the coding methods to code signals in the cochlear nucleus. Right. Now, the question here is, we all do preoperative assessment, and this is what happens inside the cochlea. Transduction converts, the hair cell converts the acoustic to electrical, and these electrical signals are transmitted to the brain through the auditory nerve. And you can measure the transmission using a test called auditory brainstem response up to the brainstem. Now, what happens in a cochlea where transduction does not happen, where the sound is not converted to electrical signal, we are unable to measure the function of the auditory nerve using an acoustic stimuli. Now, how do we assess in this case? Now, before answering that question, let's also look at the other anomalies that we come across quite often. One is a cochlear anomaly. The anomaly due to developmental arrest at different period of embryology, and also the nerve anomaly. So if you look at the cross section of the internal acoustic meatus, you're supposed to see the superior inferior vestibular nerve, the facial nerve, and the cochlear nerve. Now, this is the CT and the radio imaging, and you can clearly, in a very good radio imaging, you can clearly differentiate between the cochlear nerve, vestibular nerve, and other parameters of the cochlea. Other cochlear anomalies include incomplete partition 1, 2, and 3, and cochlear nerve hyperplasia. So if you look at this image, you can see the cochlear nerve here, you can see the vestibular nerve and the facial nerve. But if you look at this image, between the right and the left, you see the cochlear nerve here, but you don't see the cochlear nerve here. Right, so this is cochlear aplasia. Now, irrespective of all these anatomical anomalies or variations, look at the results that we get when you do the clinical investigations. These are the very commonly done clinical investigations, and you see on this side of the different etiologies or different anomalies. Now, irrespective of whether the cochlea is normal or whether the cochlea is absent, you see the results are the same. You don't see any difference in the results in audiological report. So it becomes a greater challenge for us to make a decision whether this patient needs a cochlear implant or not. If he needs a cochlear implant, will he perform well, or he needs a brainstem implant? Of course, you have a radio imaging for your support, but most often, trust me, I don't trust radio imaging completely. Most often the radio imaging can be misleading. So more the data, the more the evidences we have, is much better the decision making. So what I'm going to talk today is adding an physiological evidence in conjunction with the anatomical evidence. Anatomical evidence is radio imaging. The physiological evidence is electrophysiology, EABR. That's what I'm going to highlight today. Now, this is the two cochleas. One is transducing, one is not transducing in profound loss. Now, how do we do it in this case? So we can give an electrical stimulus. Instead of giving acoustic, you can give an electrical stimulus and stimulate the auditory nerve and measure the responses of the auditory pathway. Now, this way of stimulating and recording the auditory nerve response is called the electrically evoked auditory brainstem response. This is very commonly used in cochlear implants and brainstem implants, basically to measure the function of the auditory neurons. And it is also helpful in determining the position of the electrodes, both inside the cochlea and also on the cochlear nucleus. In some cases, they are also used for predicting the stimulation boundaries post-operatively in children or patients who cannot give reliable behavioral responses. Right. Now, depending on the site of stimulation, you can classify the EABR into three types: a transtympanic EABR, intracochlear EABR, and cochlear nucleus EABR. Now, in transtympanic, depending on the position of the electrode where you place, it's promontory EABR, round window niche EABR, and the auditory nerve testing system, which is intracochlear electrode, which is developed by Medal, which is something very, very useful nowadays, which we often use in certain conditions. So these are different types of EABRs, and I'm going to focus only on the transtympanic EABR today. Now, if you look at the test setup, it is pretty much two setup. One is the recording setup, which you use your regular evoked potential device. And this is another system which is called a stimulation system, which you can use with your clinical software and the clinical trigger box. Or if you're using Medal, you use Max. If you're using Cochlea, you have pods and other stuffs. But you have two systems. One is a stimulating system where the stimulus is controlled using your clinical programming software, and the recording system, which is your regular recording EP device. And there is a cable which connects the stimulating system and the recording system. This cable is a trigger cable, which means the moment the stimulus is on, it will trigger the evoked potential device to start recording, because ABR has a time synchronous response. And the recording electrodes are very similar to acoustic ABR. And these are the two things. This is intracochlear electrode using hands, where you can place the electrode inside the cochlea. They've got 3 electrode contacts. You open the round window and then push the electrode inside, and you can stimulate the cochlea auditory nerve, or you can place the electrode on the round window niche here. This is promontory stimulation EABR. This generators of EABR, you have peak 1, 2, 3, 4, 5 at different site of generation. But usually what happens is, the focus is, when you give an electrical stimulus, you may not be able to see peak 1, because the electrical stimulus is larger than the electrical response of the nerve. So when the electrical stimulus is larger, it obscures the electrical response of the nerve. So you may not be able to see the peak 1 in a EABR, but you will be able to see peak 2 and on. Right. So this is a morphology of acoustic ABR. This is a classic morphology of acoustic ABR. Depending on the site of stimulation, the morphology of EABR will vary. If you stimulate the cochlea in using cochlear implant, look at the morphology. And if you stimulate the ABI, you look at the morphology. Morphology is quite variable. And this is a morphology of transtympanic EABR depending on the site of stimulation, from stim or intracochlear. Now I'm going to be very specific on some of the case studies. This is one patient who's 2.5 years old, auditory neuropathy spectrum disorder. He was using hearing aid for 6 months, could not see much progress with the hearing aid. It was reported left ear is better than the right ear. So we did the transtympanic EABR in this patient, but you see the right ear seems to be better than left, where the subjective response is left is better than the right. So we implanted this patient on the right side and you see a good response here. So the point I want to drive is the transtympanic EABR is also useful in selecting the better site for implantation in case of bilateral ANSJ or bilateral hypoplastic. This is another classification, but I will pass it on later to you in constraint of the time. These are different cochlear anomalies. This is IP2. Even in IP2, you can measure responses, but you see the morphology of the EABR is varying. And this is common cavity. Most important point, usually in the past, they don't do transtympanic EABR in common cavity because they can't find a round window there, round window niche there. But not necessarily, you don't need a round window niche always. You can just place it on the promontory or on the cochlea, and then you can still stimulate and record the responses. This is classic of common cavity. And this is another patient with traumatic brain injury where there is a rupture to the temporal bone and was quite query whether the nerve is functioning or not. So we wanted to do this patient wanted to go for a cochlear implant on this side because now she is single-sided deafness. But the question is, if the nerve is not functioning, we can't do a CI. So we did a transtympanic EABR, we got a beautiful response. The point is, you can see a very good amplitude growth and the latency shift with respect to the change in the stimulation levels. Another interesting case is hypoplastic nerve. In this patient where you have nerve hypoplasia on one side and normal nerve on the other side, this is a preoperative transtympanic EABR. You see responses. And we decided to do a cochlear implant in this case. You got, this is cochlear implant EABR, responses were there, intraoperative. This is post-operative CA EABR, the responses were there. So, in patients with hypoplastic nerve, if you get good responses, you can go ahead with cochlear implant. And this is another patient where bilateral hypoplasia, left ear you see some responses, right ear no responses. So we did cochlear implant in this case, and you see the difference with EABR and a cochlear implant. The point I wanted to tell you here is, whenever we have a patient with hypoplastic nerve, we always choose to go for a longer electrode. So my choice of electrodes would always be metal, because the more deeper you go, you tend to stimulate more spinal ganglion cells. In hypoplastic nerve, you don't know where the spinal ganglion cells are lying. So that's why the morphology of EABR cochlear implant is better than from stim. This is another case with ossified cochlea. We have two problems in ossified cochlea, whether the spinal ganglion cells are functioning or we're getting a facial nerve stimulation. If you look at the response, this is the auditory response, peak 5, but this is non-auditory. You also get facial nerve stimulation. So we changed the mode of stimulation from biphasic to triphasic with the same stimulation level. You see the facial nerve stimulation goes down. So the point is, you can decide whether the patient is able to hear, whether there is spinal ganglion cells to give some auditory sensation. You will also be able to tell whether it's giving facial stimulation at what level. If you're getting a facial stimulation even at a lower level, then I wouldn't suggest a cochlear implant because you can't do post-operative mapping. Before you could reach a comfortable level, the patient will start having twitches. This is another patient quickly who did, there was a hypoplastic nerve, the left side no response, right side some response. We did a cochlear implant, some auditory response was there, but lot of facial responses. The patient is not progressing, so we decided to go for ABI later, and we see intraoperative ABI responses. So now, if you add these EABR and aided cortical potentials to it, you could see some difference. You could see some. Okay, you could see some of the informations which is present using the EABR, which will help us to make some decision. in terms of hypoplastic nerve. Okay. Just to conclude, last slide. Am I? Yeah. To conclude, TT-ABR is a useful tool, and however, you need additional tools to complement it. In patients with anomaly, ABI is not the first choice of treatment. You always give a choice with cochlear implants. And if you have any questions, please feel free to contact me, and I'll be happy to address it. And the take-home message is, auditory test battery is very, very important. If you use only one tool, then everything looks like a nail. Thank you.